Welcome to the American Academy of Child and Adolescent Psychiatry webinar, Introduction to 2021 Office and Other Outpatient Evaluation and Management Codes. I am Benjamin Shane, MD, PhD, the ACAP CPT Advisor to the American Medical Association CPT Advisory Committee and co-chair of the ACAP CPT and Reimbursement Committee. This webinar is the first of two based on the 2021 CPT Professional Manual from the AMA. I suggest that before you go any further in this webinar, you print the webinar slides and have them available for taking notes. Please contact Karen Ferguson with any questions after you finish the two webinars. Karen is a wonderful committee staff person and will either answer your questions or pass them on to the committee. Now for the adventure. This webinar is going to quickly discuss the structure of evaluation and management codes, and then go into the basic and unique features of the 2021 Office and Other Outpatient E&M codes, namely coding based on time, including prolonged service, and coding based on medical decision-making. Evaluation and management codes are mostly divided into families. This includes site of service, such as office and other outpatient and inpatient, and patient status, such as new or established. The level within each code family is denoted by the fifth digit of the code. This webinar only concerns the three code families that change in 2021, namely Office and Other Outpatient New Patient, Office and Other Outpatient Established Patient, and prolonged service for these codes. For now, the other families remain the same and have the same rules for code selection that they have had all along. This means that there are two definitions for both medical decision-making and time, one for office and other outpatient, and one for the rest of the E&M codes that rely on medical decision-making. Notably, unchanged codes include those for hospital inpatient, including PHP and IOP, and consultation. Unchanged code families include hospital inpatient services, which include services for patients in partial hospital and intensive outpatient programs, and consultation services for office and inpatient. The definition of new versus established patient has not changed. On the other hand, this definition has been a source of confusion for years and so worth paying attention to. A new patient has not received a service from the provider billing the service or from another provider in the same group and the same specialty and subspecialty in the last 3 years. The service in the last 3 years is any service. So if the patient were admitted to the hospital or seen for psychotherapy by a child and adolescent psychiatrist in your group in the last 3 years, the patient is established, not new. A patient seen by a physician who is covering or on call counts as having been seen by the physician who is not available. A patient seen by an APN or PA counts as having been seen by the physician with whom they had been working. The code level is selected based on either time or complexity of medical decision-making. Which of those two is used is strictly the option of the physician, although, of course, the option used and the criteria for that option must be documented. One exception to this choice is when a psychotherapy add-on code is reported on the same day as E&M. Just as prior to 2021, the E&M code may not be selected based on time. In this case, select the E&M code based on the complexity of medical decision-making. History and physical examination are both required to the extent they are clinically indicated. Note that physical examination in psychiatry may be mostly or all mental status examination. The nature and extent of history and exam are determined by the treating physician and do not affect the level of the code being selected. The care team may collect the information and/or the patient or caregiver may supply the information as long as it is reviewed by the physician. Additional issues that do not matter in selecting the code level include extent of counseling and coordination of care. This still matters when time is used for other E&M services, such as inpatient and consultation, but not for office and other outpatient. Comorbidities, such as diabetes or asthma, only are considered in code selection when they increase the complexity of medical decision-making at today's encounter. Services that are reported with a separate CPT code are never included in the service in question. Otherwise, this would be double dipping. Time is total time, which includes all time on the date of the encounter personally spent by the physician in qualified activities to do with care of the patient. Time spent on days before or after the encounter was accounted for in valuing the codes, but is not used in code selection. Time and activities normally performed by clinical staff also does not count in code selection. This distinction is less confusing when you consider that generally time for activities done by the physician counts, and time by clinical staff does not count. A split visit is when two or more physicians or other qualified healthcare professionals, for example, two physicians or a physician and an APN, jointly provide the work related to the particular visit. Complexity of medical decision-making may be used to determine code selection. However, when time is used, the time is summed of the personal time of each of the physicians or other qualified healthcare professionals. CPT does not address time spent by trainees, although individual payers may do so. An important exception to the sum time is that it only includes distinct time. When the professionals are both working during a period of time, such as meeting to discuss the patient, only the time of one of the individuals is counted. Again, activities on other days are not included in total time. Activities performed on other days have been averaged to determine reimbursement, but should not be included in total time to select the code level. Activities on the day of the visit that count are preparing to see the patient, obtaining and/or reviewing separately obtained history, performing a medically appropriate examination or evaluation, counseling and educating the patient, family, or caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals, documenting clinical information in the electronic health record or other record, independently interpreting results, this is not separately reported, and communicating results to the patient, family, or caregiver, and care coordination. Note that none of these activities is psychotherapy. To report psychotherapy, use the psychotherapy codes. These are the time ranges for the various codes when using time for code selection. An easier way to remember these times is to think of them as minimum times and remember the low end of the range. Thus, 99202 is a minimum of 15 minutes, 99203 is a minimum of 30 minutes, etc. Until you learn these, reference the Office E&M Summary Guide, which may be downloaded from acap.org. There is less to remember than what appears because most child and adolescent psychiatrists only use 5 of these codes on a regular basis. 99204 is 45 minutes, 99205 is 60 minutes, 99213 is 20 minutes, 99214 is 30 minutes, and 99215 is 40 minutes. 99417 is a prolonged service code designed for use with the 2021 Office and other outpatient E&M codes. It reports total time when that time exceeds by 15 minutes or more the minimum time of the two longest codes, 99205 and 99215, and time is used for code selection. 99417 is not reported when the code is selected based on complexity of medical decision-making. Each unit of 99417 reports 15 minutes of additional time, but not any increments less than 15 minutes. 99417 may be used repeatedly, once for each increment of a full 15 minutes that exceeds the total time for 99205 or 99215. For example, When total time for an established patient is 75 minutes, 99215 is reported, accounts for 40 minutes, along with 2 units of 99417, accounts for another 30 minutes. The last 5 minutes is not reportable because it is less than 15 minutes. In summary, 99417 is prolonged office or other outpatient evaluation and management service beyond the total time for 99205, 60 minutes, or 99215, 40 minutes, each 15 minutes. When total time is selected to choose the code, the timeline for new patients starts at 15 minutes. Less than 15 minutes is not reportable using time. The timeline is part of the E&M summary guide, and so have this with you until you memorize the minimum times. The timeline for established patients starts at 10 minutes. Less than 10 minutes is not reportable using time. Again, the timeline is part of the E&M summary guide, and so have this with you until you memorize the minimum times. Medical decision-making is more complicated to use, but also may be more rewarding because it accounts for physician efficiency. My recommendation is to use medical decision-making whenever you can when you are being efficient. There are ways to simplify medical decision-making. We will be getting to those a little later. Similar to legacy medical decision-making, still in use for other E&M codes, medical decision-making for 2021 office and other outpatient codes is establishing diagnoses, assessing conditions, and/or selecting management options. Medical decision-making includes 3 elements: problems, data, and risk. Legacy number of diagnoses and management options is now number and complexity of problems, which is actually what has been used all along to measure this element. Remember problem points? The definition of legacy, amount and/or complexity of data to be reviewed, has been refined into 3 groups. 1, the number of unique sources of data in addition to the patient. Each unique test, order, or document is counted to meet a threshold number. 2, independent interpretation of tests. I'll get into the definition of that later. And 3, discussion of management or test interpretation with external physician or other qualified healthcare professional or appropriate source. I will also be defining appropriate source later. Risk of significant complications, morbidity, and/or mortality has been narrowed to the risk of management options, including tests and treatments made at the visit. Importantly, this also includes the risk of management options that were considered but not selected based on shared medical decision-making. Before I go on, a note on how this webinar uses examples. Official examples are taken directly from the CPT manual. Examples approved by the ACAP CPT Coding and Reimbursement Committee are also used to illustrate specific criteria. CPT and ACAP examples will always be differentiated. In this case, psychiatry was explicitly mentioned in the CPT manual, which gave the example of a psychiatric patient for whom hospitalization was considered but not selected based on sufficient degree of support in the outpatient setting. In this case, risk may still be based on hospitalization, even though the patient was actually not hospitalized. It is key to document shared medical decision-making, which involves eliciting patient and/or family preferences, patient and/or family education, and explaining risks and benefits of management options. This is the full medical decision-making table, which you can find in the Office E&M Summary Appendix. The codes are selected based on the best 2 of 3 elements of medical decision-making. Needless to say, this table is complex. This table may be greatly simplified, however, for all but rare psychiatric encounters. Risk examples such as decision regarding minor surgery with identified patient or procedure risk factors, and decision to not resuscitate or to de-escalate care because of poor prognosis may be removed. The entire data element, the middle column, may be removed. Of course, psychiatric encounters still include data. Common elements for psychiatry include review of prior external notes from each unique source and assessment requiring an independent historian. That said, this column is still not generally helpful for psychiatric encounters. Several factors tend to keep the data column from being that useful. Problems really boils down to risk from the underlying illness or injury, largely taken from the CMS Table of Risk in the 1995 and 1997 Evaluation and Management Documentation Guidelines. Risk is risk from selected or considered management options in the same CMS Table of Risk. Typically, risk from the illness and risk from the management options run in lockstep. Even if criteria for data are higher, medical decision-making needs the best two of three, and so, if problems and risk are the same, those determine the medical decision-making complexity. In the less usual case when problems and risk are not the same, psychiatric encounters do not typically have enough data elements to get to the next level. And if you are doing a lot of, say, talking to other providers and discussing tests with the physicians who did them, you probably got to the next level anyway based on time. With those deletions, the table is now much simpler. I suggest that you memorize this, and until then, carry around a copy of the Office E&M Summary Guide. Now we will define each of these terms, starting with number and complexity of problems addressed or just problems. Now for the really fun part, learning what all those items on the table mean. The CPT manual gives a number of definitions. Nearly all of those are reproduced here, as well as in the E&M Summary Guide appendix. Problem is defined as a disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter addressed at the encounter, with or without a diagnosis being established at the time of the encounter. I suggest that your documentation breaks down what the problems are and not leave this to the auditor to infer. To count, though, a problem needs to be addressed or treated. Included in this is a problem that is considered for further testing or treatment that is not selected based on provider analysis or patient-family choice. An ACAP example is medication is considered but not prescribed based on shared medical decision-making. Addressed or treated does not include problems that are strictly managed by another professional or referred without at least some evaluation by the reporting physician. An ACAP example is diabetes mellitus that is simply mentioned. A problem, though, that has assessment, such as by history or exam, consideration of treatment, or care coordination at the time of the encounter does qualify. An ACAP example is diabetes mellitus, accompanied by a discussion of the impact of the disorder on psychotropic medication management. At the top is a problem that does not require the presence of a physician, but the service is provided under the physician's or other qualified healthcare professional's supervision. On the table, this is listed as NA. An ACAP example is a patient who comes to the office to be weighed. Next is a self-limited or minor problem. A self-limited or minor problem is likely transient and not having lasting effects. An ACAP example is brief, mild depression from a recent romantic breakup in an otherwise stable individual. Stable chronic illness is in two places. There are several issues in the definition of stable chronic illness. I'll start with chronic. Chronic refers to a problem with an expected duration of at least a year or until the death of the patient. This expected duration should be based on what is typical of the particular illness and the patient's situation. An ACAP example is depression in a patient who is likely to feel better within months, but who is expected to need treatment or monitoring for the illness for a year or more. This should be considered chronic. Furthermore, all stages and severity changes for the illness are lumped together for the sake of CPT coding. An ACAP example is major depression recurrent severe and major depression recurrent in remission are a single chronic condition, as long as you are still assessing and or managing the depression. Stable has to do with the particular patient and their treatment goal. Even if the condition has not changed recently and there is no short-term threat, a problem is not stable until the treatment goal is reached. A CPT example of not stable is a patient with poorly controlled blood pressure, but the blood pressure has not been changing and the patient is asymptomatic. An ACAP example of not stable is a patient with persistent mild depression. In addition to all of this, a patient with a stable chronic problem must have a significant risk of morbidity without treatment. CPT examples of stable chronic illness are assuming minimal or no symptoms or side effects, well-controlled hypertension, non-insulin dependent diabetes, cataract, and benign prostatic hyperplasia. ACAP examples of stable chronic illness: major depression with minimal or no symptoms or side effects of treatment, and well-managed ADHD, both requiring maintenance treatment of some kind to maintain stability. Next is acute uncomplicated illness or injury. An acute uncomplicated illness or injury is recent and short-term, but is something for which treatment is considered. The risk of morbidity, even without treatment, is low, and full recovery is expected. This could include a problem that is normally self-limited or minor, but is not resolving as expected. CPT examples are cystitis, allergic rhinitis, and simple sprain. An ACAP example is a romantic breakup producing persistent and longer than expected mild depression. Next is chronic illness with exacerbation, progression, or side effects of treatment. A chronic illness with exacerbation, progression, or side effects of treatment is acutely worsening, poorly controlled, or progressing. For poorly controlled, think of the high blood pressure example, which qualifies even if the blood pressure has not changed recently and the patient is asymptomatic. Or an ACAP example of a patient with bipolar disorder and well-controlled mood symptoms, but undesirable weight gain from the medication. There is intent to control the progression, and additional care or attention to treatment side effects is required. Hospital-level care is generally not considered. Additional ACAP examples are persistent or episodic mild to moderate depression for which a treatment change is considered, and a child with ADHD who has been doing well in school but requires attention to poor appetite from stimulant medication. Next is undiagnosed new problem with uncertain prognosis. An undiagnosed new problem with uncertain prognosis includes a problem with the differential diagnosis with a high risk of morbidity without treatment. Undiagnosed implies that further testing is indicated to make the diagnosis. A CPT example is a lump in the breast. An ACAP example is very poor school performance in a child with no diagnosed condition or circumstance to explain it. Now it is time for a short break to get your head back together. Put the video on pause, get another cup of coffee, and then you're in for a treat. You're going to come back and watch a few of my vacation pictures from Africa before we get back to business. This is how we should be feeling, given that even though the 2021 codes are complicated, they are far less so compared to what there was before. Divine intervention may still be needed, though. I understand. You may not be quite sure that this is what you want. Now, back to the codes. Next is acute illness with systemic symptoms. Systemic symptoms is an important category to get to both 99214 and 99215 with an acute condition. I'll get to 99215 later, but for 99214, an acute illness with systemic symptoms has systemic symptoms such as low energy, poor sleeping, or decreased appetite, and a high risk of morbidity without treatment. This does not include systemic symptoms resulting from a minor illness. CPT examples are pyelonephritis, pneumonitis, and colitis. Psychiatric disorders are thought to encompass emotional and behavioral problems, and so involvement of other areas of the body might not be considered. ACAP submitted a Q&A to address this issue, and this was published in the November 2020 CPT Assistant. The question was, when determining the complexity of medical decision-making for selection of the level of an office visit evaluation and management code, may certain acute psychiatric illnesses be considered acute illness with systemic symptoms? The answer is yes. Psychiatric disorders are not limited to emotional and behavioral problems. The CPT code set defines acute illness with systemic symptoms as an illness that causes systemic symptoms and has a high risk of morbidity without treatment. Systemic symptoms such as changes in sleep, appetite, energy, restlessness, and muscle tension may be associated with a variety of psychiatric disorders. In addition, certain psychiatric conditions, including depression, psychosis, and post-traumatic stress, should be considered as causing systemic symptoms based on their association with metabolic, cardiovascular, and other inflammation-related disorders. I recommend that you still document systemic symptoms when these are observed. However, this Q&A in CPT Assistant means that for the purpose of determining the complexity of medical decision-making, acute depression, psychosis, and post-traumatic stress are considered inherently acute illness with systemic symptoms, as long as there is a high risk of morbidity without treatment. Next is acute complicated injury. An acute complicated injury may not sound related to psychiatry, but think of the CPT example, head injury with brief loss of consciousness, that is being managed for possible emotional sequelae. Nonetheless, the definition is an injury which requires treatment that includes evaluation of body systems that are not directly part of the injured organ, the injury is extensive, or the treatment options are multiple and or associated with risk of morbidity. Next is chronic illness with severe exacerbation, progression, or side effects of treatment. A chronic illness with severe exacerbation, progression, or side effects of treatment has several elements to which to pay attention. 1, the illness must be chronic. 2, the exacerbation, progression, or side effects must be severe and have significant risk of morbidity. And 3, hospital care may be required. ACAP examples are a patient with a history of bipolar disorder, now in a manic episode, and an extensive rash in a patient treated with lamotrigine. Next is acute or chronic illness or injury that poses a threat to life or bodily function. An acute or chronic illness or injury that poses a threat to life or bodily function is any of the lower level conditions, an acute illness with systemic symptoms, or an acute complicated injury, or a chronic illness or an injury with exacerbation and or progression or side effects of treatment, that poses a threat to life or bodily function in the near term without treatment. Note that the criteria for one of the lower level conditions must be met in addition to the threat to life or bodily function. For an acute illness, this includes to also have systemic symptoms. CPT specifically recognizes that psychiatric illness with potential threat to self or others may be acute or chronic illness or injury that poses a threat to life or bodily function. An obvious ACAP example is major depression with suicidal ideation and the patient determined to be at near-term risk of suicide without treatment. Now for risk, actually called risk of complications and or morbidity or mortality from patient management. CPT goes to significant length to define risk. Risk is the probability and or consequences of an event. The assessment of the risk level is affected by the nature of the event under consideration and not just the probability of the event. CPT examples of this are a low probability of death may be high risk, whereas a high chance of something minor may be low risk. Definitions of risk are also based on behavior and thought processes of physicians in the same specialty. For example, acute chest pain may be higher risk in the office of a psychiatrist than it would be in the office of a cardiologist. For the purposes of medical decision-making, level of risk is based on consequences of the problems addressed when appropriately treated, but also related to treatment and tests either ordered or appropriately considered and not selected after shared medical decision-making with the patient and family. For example, as stated earlier, a decision about hospitalization includes consideration of alternative levels of care and may not result in a recommendation for hospitalization. Risk is determined by decisions made at the visit, associated with the patient's problems, the diagnostic procedures, and the recommended treatments. The treatments include the possible management options selected and those considered, but not selected, after shared medical decision-making with the patient and/or family. CPT examples are decision about hospitalization includes consideration of alternative levels of care, such as psychiatric patient with a sufficient degree of support in the outpatient setting, and decision to not hospitalize a patient with advanced dementia with an acute condition that would generally warrant inpatient care, but for whom the goal is palliative treatment. Morbidity includes an expectation of substantial duration, of limited function, impaired quality of life, or long-standing organ damage despite treatment. The medical decision-making table gives a few examples of risk. An example of moderate risk is prescription drug management. This is a key way for psychiatrists to get to 99214. Prescription drug management is not defined by CPT. The ACAP interpretation is that prescription drug management includes monitoring effectiveness and side effects of one or more prescription medications, but does not require a script, either new or renewal, or a dose change during the encounter in question. Alternatively, prescription drug management also includes not prescribing medication after documented shared medical decision-making at the encounter. Another example of moderate risk is diagnosis or treatment significantly limited by social determinants of health. Social determinants of health are economic and social conditions that influence the health of people and communities, such as the CPT examples of food or housing insecurity. An ACAP example is significant family tension. An example of high risk is drug therapy requiring intensive monitoring for toxicity. Drug therapy requiring intensive monitoring for toxicity has several elements. 1. A drug that requires intensive monitoring is a therapeutic agent that has the potential to cause serious morbidity or death. 2. The monitoring is performed for assessment of these adverse effects and not primarily for assessment of therapeutic efficacy. 3. The monitoring should be that which is generally accepted practice for the agent, but may be patient-specific in some cases. 4. Intensive monitoring may be long-term or short-term. Long-term intensive monitoring is not less than quarterly. 5. The monitoring may be by a lab test, a physiologic test, or imaging. Monitoring by history or examination does not qualify. And 6. The monitoring affects the level of medical decision-making in an encounter in which it is considered in the management of the patient. I'm not going to read the CPT examples. ACAP examples of intensive monitoring are monitoring for neutropenia for clozapine and monitoring level as well as renal and thyroid function for lithium. Note that monitoring does not qualify if the primary reason for the monitoring is therapeutic effect, or if the frequency for ongoing monitoring is not needed at least quarterly. I know I told you that the data column will be rarely used. The actual name of the column is amount and/or complexity of data to be reviewed and analyzed. For the sake of those rare times when it is useful, I'm going to go through how to use this column and, a bit later, definitions of certain terms in this column. The algorithm is a bit different depending on whether the data is limited for 99203 and 99213, moderate for 99204 and 99214, or extensive for 99205 and 99215. For limited, the requirement is at least one of two categories. Category 1 is a combination of two from review of external notes from each unique source, review of the results of each unique test, and ordering of each unique test. That means you would qualify if, for example, you reviewed two external notes, you reviewed one note and one test result, or you ordered two unique tests. I hope you get the idea. Category 2 is assessment requiring an independent historian. For moderate, 99204 or 99214, the requirement is one category out of three, but the categories are a bit different. I'm hoping that you have the E&M Summary Guide appendix in front of you so you can read this, but keep in mind you can generally ignore this entire column because it is rarely used, as I said. For high, 99205 and 99215, the categories are the same, but the requirement is at least two of them. I'm going to go through definitions of certain terms in this column. We will first talk about tests in the context of tests and documents. Tests are imaging, laboratory, psychometric, or physiologic data. The number of unique tests is determined by the CPT code set. So, for example, a basic metabolic panel, code 80047, is a single test. An ACAP example is use of a validated rating scale to determine the level of depression. Now we will talk about external in the context of review of prior external notes from each unique source. External records, communications, and/or test results are from an external physician or other qualified healthcare professional, or from an external facility or healthcare organization. I'll get to the definition next of external physician or other qualified healthcare professional. External physician or other qualified healthcare professional is also used in another criterion: discussion of management or test interpretation by external physician or other qualified healthcare professional / appropriate source. An external physician is not in the same group practice or is in a different specialty or subspecialty. This may also include an organizational provider. External physician or other qualified healthcare professional does not include a professional who is not in healthcare, such as a teacher. A non-healthcare professional is designated as an appropriate source. An appropriate source includes professionals who are not healthcare professionals but who are involved in the management of the patient. For example, lawyer, PO, case manager, teacher. This does not include discussion with family or informal caregivers. So, looping back, an external note could be from an external physician, who could be either someone not in your group or in your group but in a different specialty or subspecialty. On the other hand, a note from a facility or organizational provider must be from a different one from the one at which you work to qualify as external. Sorry, this is complicated. Next is the definition of independent historian. Assessment requiring an independent historian appears in 3 places. An independent historian is an individual who provides history in addition to that obtained from the patient. The individual could be, per CPT examples, a parent, guardian, surrogate, spouse, or witness. This independent history should be because 1. The patient is unable to provide a complete or reliable history. 2. A confirmatory history is judged to be necessary. Or 3. There is conflict or poor communication between multiple historians and more than one historian is needed. Remember interactive complexity? It finally made it to E&M. Number 2, a confirmatory history is judged to be necessary, was added to account for the common practice of obtaining history from parents and other historians on a consistent basis. Document, however, that this confirmatory history was necessary. Next is the definition of independent interpretation of a test performed by another physician or other qualified healthcare professional, not reported separately. An independent interpretation of a test has several elements. 1. The test must have a CPT code and an interpretation or report is customary for this service. 2. This is not for the physician who has or had reported the service with a separate code. 3. The interpretation should be documented, but need not conform to the usual standards for reporting this particular test. And 4. The test must have been performed by another physician or other qualified healthcare professional. Most likely, interpretation of a rating scale administered by you or your office does not qualify for this criterion. 1. It is not performed by another physician. And 2. There is no CPT code for the interpretation of a rating scale. 96127 is the code for the administration of the test, not the interpretation. Codes for interpretation of psychological and neuropsychological tests start with first hour, and so require at least 31 minutes, much more than what is involved in interpreting a rating scale. You have gone through a lot of material, and your head may be spinning. Once we learn the codes, though, we are going to like the result. Stay tuned. Watch our webinar number 2, Clinical Examples, for practical tips of how to use these codes.